After thrombi, we'll now deal with benign masses. Now, benign masses are actually, when you compare them to malignant masses, much more frequent, which is good. Let's take a look at the kind of masses you will find in the heart. Here, as you will probably easily appreciate, we have a structure attached to the intraatrial septum, which is mobile and which has a round shape and a more or less smooth surface. I guess most of you already know the diagnosis. This is the most common form of benign tumor. This is a myxoma. Let's take a look at myxomas. 50% of all primary tumors are myxomas. So myxomas are most commonly present in the left atrium, approximately 86%, but you can also have them in the right atrium, but even in other parts of the heart as well, but very rarely. They are usually located in the fossa ovalis, where they arise as a pedunculated polypoid structure. They are usually round or oval, but you can at times find lobulated myxomas as well. They have a smooth surface, and often it is covered with thrombotic material, which is one of the reasons why these myxomas also have a predisposition to embolize. Now, the morphology of a myxoma is so characteristic that given in a typical presentation, echo is virtually diagnostic. What is the risk of having a myxoma? It's embolization. Approximately 29% of all myxomas show some form of embolization, and that can be either cerebrovascular, into the eye, into the extremities, and patients can also develop fever. Usually you have an elevation of infectious parameters if you have a myxomas, maybe because interleukin is somehow activated in such patients, and the patients often present with malaise, with fatigue, and with fever and elevated infectious parameters. There are also familial forms of myxomas, but generally if you operate on a patient with a myxoma and remove the myxoma, the patients don't get recurrences. What are some of the things that you should be looking for if you have a myxoma? Here's a beautiful example that shows, I would say, a mid-sized myxoma. What we do here is we usually measure the distance, and we measure it in 2 dimensions, so in a longitudinal direction and also in a transverse direction. If you want to, you can also measure the area, but honestly, I don't see very much sense in it. More important is, aside from the fact to describe where the location is, also to look for obstruction of the mitral valve. And you see that actually happening here. The myxoma reaches all the way to the mitral valve and probably causes some degree of mitral valve obstruction. We'll see more cases, for example, here. This myxoma is huge, I would say. Now, myxomas are usually, as I mentioned already, slow-growing tumors, and this must have been probably in the patient for several years until it got to this size here. It fills almost the entire left atrium and definitely causes inflow obstruction, not only across the mitral valve, but also into the left atrium because it is so large. This is an example of, I would say, a smooth myxoma. The surface is rather smooth and it's very homogeneous, something that is not always present in all myxomas. Here is such an example of a myxoma that is more lobulated. You see, it doesn't have a smooth surface. It again arises from the intraatrial septum and protrudes into the left ventricle. And by doing so, it probably causes some degree of obstruction, which is not significant. How do you look at obstruction? The same way you would as in mitral stenosis. You look at color flow and you look at continuous wave Doppler to look for elevated gradients. Flow obstruction can not only occur on the left side of the heart, but also on the right side of the heart. And here is an example of a right-sided myxoma, almost the same size and the same appearance as the one I showed you previously, only that this time it is on the right side. Here again you see the turbulent flow across the tricuspid valve here, and this definitely causes tricuspid regurgitation as well because the tricuspid valve is impaired in its function. 3D echo allows us to look at the myxoma in 3 dimensions. It's a nice way of displaying a myxoma, but actually there is not much additional information. As I already mentioned, 2D echo is very frequently already diagnostic of a myxoma. We can also use other imaging modalities. This is an example of cardiac MRI, where we see here the myxoma. And we can also use TE. As a matter of fact, in all patients where we have the suspicion that there is a myxoma, we perform an additional transesophageal echo, because there we can delineate the tumor much better. We could detect whether or not a second myxoma is present and provide important information for the surgeon, because myxomas, especially if they're on the left side, should be removed. Why? Because they have a higher risk for embolization. Here's another TE study showing you a lobulated form of a myxoma, very large again protruding through the mitral valve and causing some degree of mitral valve obstruction. Another reason why we should remove these tumors. Here's the same patient, again to demonstrate how large this myxoma actually is. You can imagine that there's probably a higher risk of embolization, especially if these myxomas are lobulated. And we see color Doppler here as well flow around this myxoma. Good, so those are the most common benign tumors, the myxomas. But what are the other potential benign tumors we can find? Well, that depends very much on whether or not you're an adult or you're a child. In adulthood, the second most common benign tumor, at least as it is found in the literature, are the lipomas with 21%, followed by the fibroelastomas. In the child, it is the rhabdomyoma. Let's take a look at a lipoma. Now, lipomas can appear very variable, probably depending on how dense the lipoma is. In most cases, they are rather echogenic and they kind of seem to glow a little bit. And lipomas can be intramyocardial, but they can also be on the surface. Of course, I cannot make the true diagnosis of a lipoma just by looking at the echo. You have to have, I would say, the biopsy, or at least the result of histology, to confirm that. The true problem in most cases is that we do not know what the dignity of such a mass is, because in most cases, especially if we find such a mass in elderly patients, we would not perform biopsy, we would not necessarily perform surgery. As long as we can assume that the mass is benign and we don't see any growth of the mass, we would be more conservative, and therefore we have very many masses which are unknown with respect to their dignity. Lipomas can be located on the mitral annular ring as well. Here's an example, again a tumor that glows very much, which is difficult sometimes to differentiate from I would say caesious mitral annular calcification and normal mitral annular calcification. And of course, since the tumors grow and if they're in the region of the mitral annulus, they too can lead to some degree of obstruction. Now, this is the differential diagnosis I talked about earlier in an earlier part of this section and just mentioned in the previous slide. This is the so-called caesious mitral annular calcification, or also toothpaste lesion. Why is it called a toothpaste lesion? Because it's a mass. When you open it, it has kind of a toothpaste-like appearance, a caesious appearance. And it looks very much like mitral annular calcification, with the only difference that it doesn't really go around the rim of the posterior annulus, but it is a more round structure. It's unclear what the structure really is and why people develop such a mass. In any case, it's a benign tumor that you do not necessarily have to operate unless it causes some form of flow obstruction. Here's a beautiful example of the same patient now in a transesophageal study. You see again, it's a very round mass located here in the posterior part of the mitral annulus. Here again, this is the 3D study. You see that it is not located around the entire circumference, but it's only located here in this part. This separates it from the classic mitral annular calcification. One more example of a toothpaste lesion, which highlights that the typical echo finding is that of a more echogenic surface and a more echolucent center of this mass, a round mass right here and right here. So I think this is clear to see. And again, we performed a TE study in this patient, and it looks very similar. I just like these images, they're very spectacular. And they do add a little bit of additional information because they show the true extent of the mass. Here again is the mass in the TE study. Let me just go down a little bit here. And this is the mass right here. Let's summarize lipomas. Lipomas are the second most common benign tumor. The most common location is the left ventricle and the right atrium, and the intraatrial septum, where they can sometimes look a little bit like lipomatous hypertrophy or the so-called dumbbell pathology that we talked about previously. Sometimes we can see those lipomas intramyocardials, where they just appear as a fuzzy kind of a mass inside the myocardium. And the way we usually try to diagnose it, we send these patients to MRI and CT, and especially with MRI, you can kind of help yourself with characterizing the tissue, because with MRI you can detect fat, and that sometimes can lead to the diagnosis of a lipoma. And here is the third most common benign tumor, the fibroelastoma. Now, fibroelastomas can be quite difficult to detect at times because they can be rather small. This example shows the typical location of a fibroelastoma, the upstream side of the aortic valve. Right here is this small structure attached to the aortic valve. It's often specifically difficult because patients, especially when they get older, also have fibrosis, and as in this patient, areas which are thickened. And it's very difficult to see these structures, but what you should be looking for is you'd be looking for the mobile part of the aortic valve, or the mass, which is indicative that there is truly something on the valve. Of course, if I do not have the information that this patient has no fever, it could just as well be endocarditis, even though endocarditis is more on the other side, on the LVOT side of the aortic valve. We confirmed the fibroelastoma with transesophageal echo. You can nicely see it here on the right coronary cusp, right here. Small mobile structure. This mass is relatively, I would say, stable and not very mobile, opposed to this example right here. Again, a TE study showing you a fibroelastoma which is a little bit larger than the one we saw before and a bit more mobile. And sometimes these fibroelastomas can be, I would say, pedunculated and relatively large, and even have a flotating motion very similar to endocarditis. There's been some examples of fibroelastomas which actually protrude into the coronary arteries and thereby cause obstruction. So fibroelastomas, despite the fact that there are benign tumors, are no harmless tumors, because as I just mentioned, they can cause coronary obstruction and even more so cause embolization. And this is the reason, if possible, the fibroelastoma should be removed and operated. It's a typical source of embolism. But fibroelastomas are not only found on the aortic valve, they can be found on many other structures as well, as for example in this example where we have one on the mitral valve. Now, this structure here actually appears more like, I would say, a myxoma, which is lobulated. And the diagnosis of a fibroelastoma was made after removal of the tumor and looking at the histology there. So again, transthoracic echo cannot always confirm what type of mass it is. We can only get clues as to which direction it could go. And here's one more mass where we truly know what type of mass it was, a fibroma. But I would say it looks very much like the masses we saw before. There's just a little nodule on the aortic valve. It could just as well be a fibroelastoma. So in reality, the truth is, in many cases, we don't really know what the origin of the mass is or what histology it is. It's like the unknown soldier. And I could show you hundreds of cases of pathologies of masses where we don't know what they are. Here's one example, an elderly lady that presented with this. As long as we can exclude that it is endocarditis, and as long as we at least can say that it's not a malignant mass and it's stable, I would say we can follow these patients up, especially if the patients have a high risk for cardiovascular surgery. Still, in some cases, maybe even in this case, it would make sense to operate the patients because of the risk of embolization. Here is an example of a patient who had a mass here on the mitral valve as an incidental finding. And this patient had a mass here as well, and I think you might have realized that this is a mass that looks very much like a thrombus, but in essence we cannot be sure because very frequently we'll have malignant masses also in the right atrium. But coming back to the fibroelastomas, what are the facts? First of all, it's more common on the aortic versus the mitral valve. You would find them on the downstream side of the valve in contrast to vegetations. You would rarely have significant valvular dysfunction. This delineates them from endocarditis, where regurgitation is common. And sometimes you have thrombi on the surface. And finally, of course, they have a tendency to embolize. A few final thoughts with respect to benign masses. What do you do if you see such a benign mass? That depends, first of all, where the mass is. If it is on the right side of the heart, embolization is less catastrophic than if it is on the left side of the heart. It also depends on whether or not the mass causes some form of hemodynamic sequel, in other words, obstruction or compression. In the next chapter, we'll talk about a completely different ballgame, malignant masses.